Thank you. I think I want to be in Helen's team and get cakes. They looked amazing. I'd like to, I'm Kath Phillip, I'm the Chief Allied Health Advisor, and I also manage the Workforce Innovation and Reform team at the department. That's a position that I've had since 2007, and I work very closely with Brendan Murphy in that role, so some more about that shortly. Thank you to the organisers for inviting me to speak with you all. It's terrific. In the allied health world, our engagement with the oral health workforce has been one of the harder places for me to become involved in, so it's terrific to be here today. As you know, a large part of the oral health workforce is considered as part of the allied health sector in Victoria, and the appointment of a chief advisor role in Victoria for the first time at the start of last year was a major step forward in the allied health workforce being able to gain more traction in improving the health outcomes of Victorians. So my presentation today, I'm going to gallop through quite a few slides to try and give you a bit of a feel for the policy space in the department and what the department's initiatives and directions are in relation to both their health workforce reform agenda, which is the whole health workforce, and also particularly around the allied health space and what I'm trying to do in my role. I'm hoping that by doing that it may present you with some thinking around where the opportunities for new models of care and ways in which the oral health workforce can both contribute but be supported in their workforce development and in some innovative models of care. Okay. I put this slide up because I know you're incredibly familiar with DHSV, but I wanted you to sort of understand its relationship to the larger health department. The Department of Health, as you can see there, sort of sits above with the Minister, and it sets performance parameters and monitors health services in Victoria and in their service of provision. And it also undertakes statewide policy and planning for the health workforce. Now, a lot of the oral health workforce actually has more of a relation with DHSV, which particularly is interacting with some of the program areas in the department, primarily the primary care program area. But the department also has parallel bodies that look at sector-wide things, and Health Workforce Branch is one of those. And they undertake statewide policy and planning for the whole health workforce. DHSV also has a major role in the service provision of oral health services, and in the broader health sector that's the role undertaken by the health services. So DHSV has an interesting role, and it does a lot of the workforce planning for the oral health workforce, which is sort of an overlap with the Health Workforce Branch, and also provides the service. So it sort of sits almost over that whole part of what the department does and what the health services do. I hope that's clear. I think I've confused myself. Okay, so at the level of the department, you're probably familiar with this. The Victorian Health Priorities Framework was released at the start of a couple of years ago, and the principles here drive and underpin the work of the department. And our strategies at the department are aligned with these reform priorities. The outcomes being sought under the Health Priorities Framework are that people are as healthy as they can be, that they're managing their own health better, that they have the best healthcare services possible, service outcomes possible, I should say. The care is clinically appropriate and cost-effective and delivered in the most clinically appropriate and cost-effective setting, and that the health system is highly productive and sustainable. And so these reform priorities here is how we're attempting to achieve those outcomes. Within the department, as I mentioned, there are various program areas, so the primary health area, and specific health workforce branch. At the branch level, the health workforce branch level, the two units that are most applicable to my presentation today, and really what the oral health workforce is about, is the allied health unit, which is ensuring that we're training the right numbers of the right type of health workforce, and that these are distributed appropriately to meet the increasing demand for services across Victoria. And a really big part of that supply side equation is making sure we retain our skilled clinicians. A lot of the allied health workforce profiles show really high attrition rates from the late 20s, so that retention is a major policy issue for us. The other unit that's really important is the Workforce Innovation and Reform Unit. Of course, I'd say that because I manage it, but the purpose of that is to ensure that we're using our current workforce as effectively as possible. And that really means about getting the skill mix right so that we're using our highly skilled clinicians to do the jobs that only they can do, and tasks that don't require that same high level of training can possibly be done by somebody else. But in a framework that ensures that people are supported and supervised to work to the top of their scope of practice. And as Helen alluded before, the protocols that are involved in that, but also the satisfaction that comes from working as a part of a highly focused team where people are doing what they like to do best, is very high. So that also becomes a major part of our retention. My role, as I've mentioned, I have two, so it's been a very full 18 months. But I've just said particularly what we do in the innovation and reform space. A lot of that work is working closely with the Health Workforce Reform Implementation Task Force. Department loves an acronym, which is a sector-led body chaired by Brendan, and bringing together sector representatives that include CEOs, directors, executive directors of nursing, allied health people, CEOs of Medicare local community health centres, to come together to set the priorities for reform and then to drive that reform agenda forward. In Victoria, we've done a lot of piloting and have developed some very successful models since 2005. Where we haven't had as much traction is in implementing those models across the state. One of the major focuses of the task force is that statewide implementation. So that's one of my major sort of governance bodies that I work with in that space. In the other space, I have a ministerial advisory committee for allied health, which the minister had as a priority for me to establish when I was appointed to this role. I'll talk a bit more about the makeup of that shortly. And the other main body is a Victorian Clinical Training Council. It's also a sector-led body that provides governance for the workforce development agenda in Victoria. It's chaired by Professor Jim Angus, and it has a role over the clinical training education, but also in the postgraduate education that happens, whether that be really focused clinical qualifications at university, so that would include the medical specialist training right through to become, say, an orthopaedic surgeon, or whether it's in the more in the workforce development, leadership development, the softer skills that may be a big part of what your development with your employer may be. So that all sits under that body. And there's two allied health education reference groups, one for the group of allied health therapy disciplines and one for the allied health science disciplines, that are represented on that body to ensure that the allied health perspective is heard at the highest level. I'll explain a bit more about that later too. So I thought I'd look at the workforce reform part first in more detail. And this is what we're seeking to do. Meet increasing demand while maintaining or improving quality of care. Do it as effectively as possible by working smart, using our workforce well, being very innovative in how we use our skilled clinicians better, thinking outside the square. And then if that does require some additional skill sets, then working with the education sector to ensure that they can be developed. And we know from quite a lot of research that consumers are very accepting of receiving their care from a range of different health professionals, providing that they are provided with timely and appropriate information. And that means of a sort that they can understand. And it's important when undertaking reform that activity happens across all these levels. This slide is courtesy of Jerry Myer, who's the CEO of one of the National Health Trusts in the UK. And he sort of put it as though you need the macro system, which in Victoria is provided by the task force. And the task force provides leadership, communication, incentives such as statement of priorities, direction of funding, that creates the meso system, which is the culture, capacity and ability for change to happen more at the health service level. When you have those actual elements happening at the health service level, then the health service level can make the improvement, and that's the micro level, which is involving a lot of Helen's example was fantastic, so that's the micro level. But in order for Helen to be able to do that, as she alluded to, you need that leadership, you need that culture where people are prepared to work together and a space to be able to bring people together. And then for all that to happen, you need some enablers happening from that not only health service executive level, but department level. In this work, so with the task force, we've developed a few tools to help us. These are all on the website because they're quite complex slides. But this first one is an innovation roadmap, and it provides our process framework within the department that describes how we go about setting the priorities and from idea generation through to project implementation and then to rolling it right out. There's really important for these things to work that there's really constant engagement between clinicians and the department, because clinicians know how it works on the ground, and what the department thinks may be a good idea can often be completely out of step with how it works on the ground. I perhaps should have said I'm a clinician by background, I'm a physio by background, and it's been extraordinarily valuable for me, and I tell myself that for the department also, to have someone who is in that position, who understands both sides and can sort of create a bridge. The key steps in this process are issue identification. So that might be, we've got a looming shortage of nurses of about 130,000 across Australia in 20 years. So that might be our issue. Setting our broad strategic directions, refining the approach, agreeing the business cases as to exactly how we're going to do it, and then implementing the activity. Now that maybe includes something like an expression of interest round, which we've just run against some particular priorities, which was to do with care of the older person and shifting the locus of care from the acute sector back to community. So we might put out an expression of interest across Victoria, asking for people's ideas of models that they're doing in that space that we may fund them for, looking for models that are going to be transferable across the sector. And then a key part of that, of course, is the evaluation, not only of the project, but evaluating against, well, how appropriate is this at a statewide level? How realistic is it? And actually, will it have a big enough impact to be worth the investment that will have to happen in the change? And I think Helen gave really good examples of the sort of investment that's needed. Change is hard. And it requires a lot of resilience and a lot of goodwill, and it takes time to build. So you want to know that what you're striving to achieve is something that's really worthwhile and is going to be sustainable. This is the Victorian another good acronym, the VIRIAF we call it. We've developed this, it's based on the impact assessment framework that Health Workforce Australia developed. And we're using it and encouraging people to use it for all workforce redesign that they may do across the state. The advantage of using, it's quite simple, very user-friendly. It's on our website. There's a whole lot of instructions how to use it. It's deliberately designed so that you can hopefully use a lot of data sources you collect already to be able to inform your evaluation, so it cuts down on your work. But by using the same one consistently, it means that you can actually compare one project to another in terms of its impact and see which one may be more effective. But you can also roll up data from a range of projects into a meta-analysis and get really strong data to guide you going further. So I'm just going to move now on to the allied health space. So my role, as Leanne mentioned, is to provide strategic leadership for allied health professions in Victoria. And it's a little bit different from most other jurisdictions because it's actually across sectors. It's both public and private. It's the professions, not the sector. Other jurisdictions tend to be quite public sector focused. Really, my role is to try and provide a focus and a voice for the allied health workforce within government and also in the wider public space. And given that there's over 42,500 allied health professionals in Victoria, it should be a big voice, but we haven't had that big voice in the past. Bit of context, there's about 22,000 doctors and there's about 90,000 nurses. So allied health is a big workforce. I'm really focused on building connections across both the allied health sector and between the allied health sector and the rest of the health sector, enhancing leadership opportunities in allied health, which has been an area that perhaps hasn't had as much opportunity in the past, and broadly raising the profile of allied health in Victoria. So most importantly, I want to ensure that allied health is always at the table when decisions are being made. And one of the directors of allied health that I was working with recently commented, I love this, if you're not at the table, the chances are you'll end up being on the menu. And that is certainly something we've all experienced in allied health in more recent decades. So one of our key challenges in allied health, though, is striking the balance between the need to gain recognition and a sense of being an entity or a group of related professions, while also being aware of and particularly helping others to be aware of that allied health is actually very diverse, and there's a very diverse set of disciplines with diverse knowledge, skills and practice settings. And that's quite a tension. So I'll share with you my construct of allied health as an entity. It's meant to look like a forest, I hope it does. But if you think about it, a forest is not just a single tree, it's a group of trees, some bushes, saplings, probably a few creatures. But they're all at different stages of development, and some of them are big and some of them are skinny and all over the place. But it's not any more or less a forest if a new tree grows or if an old one falls over. If a fire goes through and burns a whole of the branches, you still have this concept of a forest. And so my construct of allied health is that it is like a forest. They are independent yet connected disciplines. They're quite individual and independent, but they're connected. And so we know that new disciplines will continue to emerge as technology and knowledge grows. In the same way, some disciplines will probably become less needed and probably diminish and possibly disappear. But all are valuable because all have been part of the knowledge base and that collective sense of the entity of allied health. So it is an entity, but it's not homogenous, is my key message. This graphic tells a similar story, but in a more policy-specific way. So if you think of the forest now running horizontally, these are the goals of my team and I for allied health over the short to medium term, with the core focus really on growing and retaining the allied health workforce. But depending on needs of particular disciplines within the forest or within where they are at that particular time, you may have a different focus. I mentioned about raising the profile of allied health. One of the key barriers to that has been the sense that as a group of professions it's been quite hard to engage with. Often when I'm talking about allied health and then people say, well, who should I talk to? And I say, well, there's 30 odd disciplines. Their eyes glaze over and it's all too hard. So one of the ways of doing this is to try to make allied health more accessible to people who don't understand it. So what we've done in Victoria is look at how we can categorise it or clump it into areas that have more commonality in their practice, in their training preparation, in the types of things they provide. So we've arrived at two categories, which I mentioned before, allied health therapy and allied health science. It's based on research that looks at what the core interventions of each discipline are and what the catalyst for those interventions are. And then we've contextualised it into Victoria, which had a bit more of a look around the education groups. You'll notice in this therapy group, which includes oral health, that everyone graduates ready to practice. Whereas in the science group, a number of these professions have intern years. One of the first things that happened to me last year was when the Victorian Clinical Training Council was being established. They said, we're having a discipline-specific representative from each of medicine, nursing and allied health. And I said, allied health? There's 30 disciplines. How can I have a discipline-specific one? And they said, well, we can't have 30 people around the table, which I could see. But arriving at something that where we have those education reference groups, where we have one representative from therapy and one from science. Within those groups there's quite a lot of commonality. There's also quite a lot of potential for those groups to be able to cross-fertilise in terms of positive ideas, but they have more understanding within a group to be able to represent higher. So I've consulted with all the professions and associations through the year, and basically the allied health world is fairly comfortable with this and certainly understands the need for it. I guess the other thing is a lot of my conversations might be about allied health in a cancer sense. So what they're really talking about is the medical radiations people and the medical science people. In their heads, they're not talking about the therapy group, so it helps target some of our conversations better. A really core function I see of this role is around the leadership, and both Brendan and Helen have talked about the importance of leadership, the importance of face-to-face leadership, and the importance of creating opportunities for it. So there's been a number of groups established under the Chief Advisor role. The Ministerial Advisory Committee, as I mentioned, was a key priority. The Minister wanted a sector body who could provide advice on issues as they came up and drive a work program that was very forward-focused. What are the emerging issues? What sort of models of care should we be looking at to better use the capacity and potential that sits in allied health? It was quite difficult because, again, 30-odd disciplines, you don't want a committee of 30 people. The approach we took was to invite thought leaders from across the sector, across the disciplines, of people who often could speak from a range of perspectives. That's now met 4 times. It's provided advice on a lot of issues, such as non-medical prescribing, specialist registration for other professions, Commonwealth budget impact on allied health, clinical education and other areas, as well as developing a work program. So it is on our website if you'd like more detail about who's on it. There are various other groups, some of which I've mentioned, but the purpose of these is really to bring together senior allied health leaders to to both have strategic discussion amongst themselves, but to provide that advice to the department and to together really to brainstorm about what are some of the solutions to the issues we're facing. It also provides a good peer networking opportunity and a lot of learning. So they've been successful. And the Allied Health Research Network, which I'll talk about a bit more shortly, very shortly. Another focus for me is in highlighting and growing the research-focused culture in allied health. When you look across those 30 disciplines, the commonalities in them are a real basis in evidence-based practice, a strong sort of alignment with research and the importance of it, as well as that holistic sort of patient-centred care, holistic care focus. So growing the research culture was a way of both collectively engaging everyone, but using it as a way. There's so much really good research that happens in allied health, but it often doesn't get surfaced above the discipline or above the organisation in which it happens. So part of what we're trying to do is to raise the profile of the research that's happening into the face of policymakers like myself, health service providers and executives, so that they know what's happening, but also to flag the maturity of allied health and the fact that it is based in sound evidence. Thirdly, I guess trying to create pathways for allied health professionals who are interested in taking on more of a research career. So creating opportunities both for support of them and to grow them through their career. The Allied Health Research Network has just been started earlier this year. It's being chaired by Professor Meg Morris at La Trobe University. Julie Satur from Oral Health is involved in that. And it's looking to develop a strategic approach to allied health research. There is so much happening, so trying to synthesise what's happening and looking at where the gaps are. It's very exciting because we're also, through that research network, applying for an NHMRC partnership grant based on a lot of the funding that has already gone into various things, and so we're quite hopeful we'll be able to move forward with that. Fingers crossed. I'll skim through these. We've talked a bit about the importance of having our clinicians work to the top of their scope. They need to be supported to do it, and often that might mean an assistant workforce. We're very focused on building advanced practice roles. We're currently running a series of advanced practice forums to share the knowledge of the multiple ones that are already out there so people can adopt them more quickly without reinventing the wheel, but also to raise the profile, including in places like VHIA, so that it becomes part of our industrial platform. And I'm really keen, on that previous slide, to hear what's happening in oral health in that space, because I think there's potential opportunity where we could really work together on that. And finally, what we're doing in the rural allied health space. There are a number of supports for oral health, allied health people that you may or may not be aware of when you're practicing rurally. There's access to a mentoring program to give you career guidance, to put you in touch with other people around those softer skills as to how you might develop your career. We often try and pair people with people outside of their own profession so that they can learn other parts of the health service, but also get different perspectives. Through VHA, we provide grants for continuing professional development and also postgraduate scholarships. So have a look on the Victorian Healthcare Association website. There is recruitment support for organisations, and there is in each of our regional areas an allied health program manager who runs leadership councils and things like that. So my final thought from the allied health space is that allied health, or I believe that allied health is a really key part of our healthcare system in Victoria. It needs to be recognised in every discussion about service provision. It's one of the 3 pillars of the patient care workforce, along with medicine and nursing and dentistry in this case, and it's of equal importance to that care as those provided by those colleagues. It's about getting well and leaving well, getting well and living well. That's what allied health does. And lovely quote, doctors save lives, allied health make them worth living. So I'll finish with that. Thank you.